Welcome to the online weight loss surgery information class. My name is Dr. Rod McKinley and I am the Medical Director of Bariatric Surgery here at St. Mark's Hospital. We're going to start our discussion by talking about weight control in the year 2017. We've understood a lot through the years over the research that has been done on obesity and the medical problems related to obesity, that it has a lot more to do with the metabolism inside of someone's body as opposed to simply diet and exercise, although we believe those are very important points about good weight control. So today we're going to be talking more about surgery and how that helps to alter metabolism to promote better weight control, not just in the short term, but in the long term as well. We understand that there are many components to weight control. We've already mentioned diet and exercise. We certainly encourage a healthy diet and an active lifestyle. But as we look deeper into the body's mechanisms for maintaining a healthy weight, we find that it has a lot to do with how your body processes carbohydrates, proteins, and fats and converts them into energy. So the surgeries that we'll be discussing today range in their metabolic power from the lap band, which frankly does not have a lot of metabolic influence on the body, to the duodenal switch, which is a very powerful metabolic surgery. The most common surgeries that are done today include the sleeve gastrectomy and the gastric bypass, and we will be discussing those. To give a more broad introduction, not only is metabolism involved with weight control, but our environment is a big part of it, as is one's genetic blueprint, if you will. We all come with a different genetic profile, and oftentimes weight control has a lot to do with our genes. Well, what do genes code for? They code for the hormones inside of the body, which are in charge of metabolism. And metabolism has so much to do with how hungry we are before we eat, how full we are after we eat, and how efficiently our body converts carbohydrates and fats into energy. So as we look at operations like the sleeve gastrectomy, the gastric bypass, the duodenal switch, all of these operations reduce the volume of the stomach so that they will only allow a certain amount of food into the body, thus reducing caloric intake. But more importantly, they actually reduce hunger and they create a more efficient energy metabolism inside of the body. And as that is done, then one is able to lose weight and actually enjoy the process because their metabolism is speeding up to help them along with their weight loss. We'll also be talking about some of the pros and cons of each of these surgeries. As with any surgery, there are risks associated with the operation, so we want to talk about that and allow you to become more familiar with how much weight you might lose and how your weight-related problems like diabetes, high blood pressure can be overcome on a long-term basis.
Obesity is a disease. It is not just a condition. It's not a behavioral disorder. It is a disease. And we know that because of all the different problems that we call comorbidities. Comorbidities are conditions that are either directly caused by obesity or significantly aggravated by obesity. And we're talking about medical comorbidities. There are over 65 medical conditions that are considered weight-related comorbidities. For example, type 2 diabetes really leads the list. High blood pressure, heart disease, sleep apnea, joint problems, reflux, cancer. Many people don't realize that obesity is a huge risk factor for cancer, that the 14 most common cancers that we treat in our society are increased in obese patients over non-obese patients, anywhere from double to 15 times. There are other comorbidities that are not medical though, things like clothing selection, being able to be seated in restaurants, at theaters, on airplanes, sanitation. These are restrictions due to your physical state. You can't go out to any store and buy clothes, and when you do, there's a limited selection and often increased cost. It's true that, for instance, when it comes to a job, that you're less likely to get the job if you're morbidly obese. If you get the job, you're less likely to be promoted. When it comes to professional schools, medical school, dental school, law school, studies show that any school that you have to either show a photograph or have an interview with, that you're less likely to be accepted even though you may be equally qualified. Even within the medical profession, many doctors have biases against obese patients, many nurses. It's very difficult to take care of a morbidly obese patient. Now, the real problem is the cost. The controversy, everything in obesity is controversial, even though we have plenty of science to support it. Why is it so controversial? And it's because of the misunderstanding of the cause. We're told that the cause of obesity is a behavioral abnormality, that you simply eat too much and exercise too little. So another issue with obesity is the treatments of obesity, and we're told that medical therapy is the gold standard by which the treatment of obesity should be undertaken, and I have no problem with people attempting medical therapy. The average person on that regimen will lose about 10% of their excess body weight, which is about 10 pounds at 6 months. But at 1 year, many of them have already regained it, and studies would show as soon as they go off the medication, the weight tends to come back. So not very satisfactory. Diet and exercise, we all should try diet and exercise and become a lifetime goal, but again, studies are not very promising in that regard, but it's worth trying. How about behavioral modification? I personally like journaling, but again, journaling has admittedly not been shown to really help. At least I look at what I'm doing wrong and try to work on it. How do I know that this doesn't work? Because that's what you're hearing. Well, in 1991, the Centers of Disease Control did what they call a meta-analysis. And what you do in a meta-analysis is you collect all the research data on a subject and compile that data and see if you can come up with conclusions. And the conclusion that they came up with is that less than 5% of patients could lose 10% or more of their excess body weight. And that's, again, if you're 100 pounds overweight, that's equivalent to losing 10 pounds, and keep it off for 2 years or longer. Now that's pretty dismal. The Centers of Disease Control actually comes up with obesity data about every 2 years. The last time they published their data was 3 years ago, and they found that only about 2% of patients with significant weight problems were able to control them and get them under control with medical weight loss. So unfortunately, the results are pretty dismal. We just don't have the medical tools to attack them, and that's why surgical weight loss is the most effective way of dealing with this. Morbid obesity is a chronic illness that is difficult to treat with medical therapy and exercise therapy alone. That again, they found that surgery, in that case they were talking primarily gastric bypass surgery, was the best long-term treatment. In fact, in the same document they come out to point out that it was the only reliable long-term treatment that they found at that time.
So candidates for bariatric surgery are people who have significant weight to lose. In 1991, the National Institute of Health submitted guidelines based on all of the evidence there was about bariatric surgery, and those guidelines say that anybody with a body mass index of 40 or greater is a candidate for surgery, and anyone with a body mass index of 35 or greater who also carries one of the comorbidities that we've been talking about, such as hypertension, high cholesterol, sleep apnea, diabetes, or significant degenerative joint disease. Any of those comorbidities will also qualify someone for surgery. You know, it's also important to note that there are certain psychiatric illnesses that, if poorly controlled, could also be problematic after surgery. As we've stated, you know, surgery is a stepping point in a lifelong process of change. It requires ongoing use of medications and multivitamins, and sometimes when people have psychiatric issues, they stop completely taking medications, they stop following up with doctors, and that could be potentially problematic. So that is a requirement as well, that if people do have psychiatric issues such as depression or bipolar disease, that they're well controlled with their medications. You know, another issue is alcohol or drug abuse. We have found that people after having gastric bypass surgery are more prone to alcoholism. We don't entirely know why that is. It may be a change in the way people metabolize certain drugs or alcohol, but we've also, as a result, adjusted who we consider candidates for surgery and say that nobody with ongoing or current issues with alcohol or drug abuse is a candidate. The third issue is we really try to get a sense of people that are committed to a lifelong change. Bariatric surgery is a tool. It's a tool that's going to help you lose a lot of weight, and it's a tool that's going to help you keep that weight off long term. But diet and exercise and lifestyle in general are still going to be a very key component in your ability to keep the weight off and maintain a healthy lifestyle. So people that are committed to that are also the best candidates. Bariatric surgery over the past several years has really become known as a treatment for diabetes far more than it was in the past. And in fact, it was almost an accidental discovery. We were doing these surgeries to help people lose weight, but what we found is that people with diabetes started having resolution of their diabetes to the point they don't need to take medications at all within weeks of having surgery, far before they had significant weight loss that would account for the improvement in their diabetes. As time goes on, there's more and more research being done in this area. In fact, there are even ongoing research studies going on looking at doing surgery specifically for diabetes rather than weight loss. And in some of those studies, people with a BMI down between 30 and 35 who are not normally candidates for surgery are being evaluated with very good success. What we find with the three procedures that have some metabolic effect, namely the sleeve, the gastric bypass, and the duodenal switch, is that patients that undergo the gastric sleeve, between 70 to 80% of those patients within several months experience remission, and if not remission, very significant improvement in their diabetes, to the point that, like I said, most people are able to stop taking medications completely. With the Ruiny gastric bypass, we're seeing that about 85% of people are able to stop taking medications completely. With the duodenal switch, those numbers are between 90 and 98% complete remission. Now, it's important to be noted here that as time goes on, 5, 10, 15 years down the road, in a small percentage of patients, we are seeing some recurrence of their diabetes. Sometimes that correlates with some weight regain, and other times not. So that is something that we treat appropriately if it recurs, but for most of the people who have these procedures, it does not recur that way.
Here at St. Mark's Hospital, we have a variety of surgical options. We offer the lap band or the gastric band, the sleeve gastrectomy, the gastric bypass, and the biliopancreatic diversion with duodenal switch, which we oftentimes will abbreviate or shorten to just duodenal switch. So those are 4 different operations. The 3 most common surgeries we do are the sleeve, the bypass, and the duodenal switch. And they range in aggressiveness, if you will, or degree of invasiveness. All of them involve some surgery on the stomach, and 2 of the 3, the bypass and the duodenal switch, also involve some work on the small intestine as well. I'll start off by talking about the lesser invasive ones and then proceed. We'll start by talking about the lap band or gastric band. Now, this was a very popular option. It became FDA approved in the year 2001 and probably reached a peak of popularity about somewhere between 2004 and 2010. And at that time, we were putting some lap bands in, and basically the way the surgery works is it is a ring, a plastic ring, medical grade plastic that goes around the top part of the stomach, and it acts as a brake on the food. And so it's a portion control device, if you will. The band is adjustable. It's connected, the little ring that goes around the top part of the stomach is connected by some tubing that goes to a port, which sits underneath the skin of the abdomen and is sewn onto the muscle. And we can use that port to adjust the tightness of the band. So it's been very helpful for a lot of people to lose weight. One thing we know about the band, though, and the reason it has diminished in popularity over the last 3 to 4 years, is that it doesn't affect the body hormones as much in terms of appetite suppression or control. It typically works more by a pressure phenomenon. So if someone is eating and they have a small amount of food, that band will put some pressure there where they'll feel some feedback, where they will feel full and not want to eat further. The other potential issue with the band could be heartburn, not necessarily immediately after the surgery, but maybe 2 or 3 years later, when food may have a tougher time going through and we might have to loosen the band. So for several reasons it's become a little bit less popular, but we do still offer it, and it has been a helpful adjunct in terms of getting more weight off for people. Regarding weight loss with the lap band, we typically see about 40 to 50% excess weight loss, which means that if you're 100 pounds overweight, you'd lose about 40 to 50 pounds on average. Some patients are going to lose more than that, and some probably a little bit less, and it will depend on coming back for regular follow-up visits to make sure that your band is appropriately tightened. There are some risks with the lap band as well. Heartburn is one. Nausea or vomiting could be other risks, especially if you're not taking time to chew your food thoroughly. And an additional risk, which is really quite rare with the band, would be an erosion, where the band could actually erode into the stomach, which would require its removal. Another surgery that works only on the stomach, like the band, is the sleeve gastrectomy. This surgery has become more popular in recent years. It now rivals gastric bypass as one of the more common weight loss surgeries in the country and in our practice. With the sleeve gastrectomy, we create a small tube out of the stomach. So the stomach is normally shaped like a sphere, and by using a stapling device, we are actually removing about 3/4 of the stomach, fashioning it into a tube or a cylinder. And this way, there's a little bit more pressure, a little bit more resistance into the stomach, so that when you're eating, you feel full more quickly. It also actually impacts the hormones of the body with regard to appetite and fullness, so that you're feeling less hungry even before you eat and more full after you eat a small amount of food. So the weight loss results with the sleeve are, generally speaking, higher than with the lap band. They would average between 50 and 70% excess weight loss. And they're, like the band, it does have some complications. All the weight loss procedures do. One of the potential complications with the sleeve would be heartburn. And there would be a very small risk of a staple line leak. That would be about 1 to 2%. So a very rare occurrence, but if it does occur, that would be significant and would have to be dealt with either surgically or through drains. Someone would be a good candidate for sleeve who wants to lose a significant amount of weight and who also may have had lower abdominal surgery or surgery on other parts of their abdomen, like the small intestine or the colon, or if they've had a hernia repair on the lower abdomen, which was more significant, because the sleeve will then avoid any of that scar tissue by focusing mainly on the upper part of the abdomen. It's just on the stomach. So sometimes we also think of it as a good procedure for someone who may be more medically ill, that the other two surgeries that are more aggressive, the bypass and the duodenal switch, might be a little bit too much for them, and the sleeve is very helpful in that situation. The sleeve gastrectomy appeals to a lot of people because it is more simple than the gastric bypass and the duodenal switch. It also does not affect the small intestine, and therefore there are very few, if any, absorption problems with the sleeve gastrectomy. So this would be very helpful if someone already has difficulty with iron absorption or a vitamin deficiency. Of course, we're going to recommend that for all of these surgeries that you take your vitamins carefully and completely after the surgery. The sleeve, though, really is focused exclusively on the stomach. We don't see any problems with bowel obstruction or any kinking or twisting of the small intestine, because we are simply not operating on that part of the body. It also tends to appeal to people who are looking for the surgery that will have the lowest surgical complication risk, but still get them at least 50% excess body weight loss.
The Ruiny gastric bypass is a procedure that kind of came about as a combination of several things. Dr. Rue started doing this procedure a century ago to treat patients where he had to take out a significant segment of their stomach and find a way to reconnect things. Then in the 1950s and 60s, when we were doing a lot of surgery for ulcer disease, we found that a Ruiny was much better than some of the alternatives because of the long-term lack of side effects. But as a kind of an accidental discovery, we also found that patients that were having this surgery done to treat their ulcers, if they were significantly overweight, lost a significant amount of weight. And that's what drew the attention of the bariatric community. The first Ruiny gastric bypass that was done for weight loss was in the mid-1960s. Since then, it's been done all over the country because of its great success. We transitioned to doing this surgery laparoscopically in the early 90s, and ever since then it's been done in that manner. It's worth noting that once we transitioned from doing open surgery to laparoscopic surgery, the risk of having complications or repeat surgeries, etc., significantly decreased. At this point, most people who undergo a Ruiny gastric bypass can expect a weight loss of between 60 and 80% of their excess body weight by about 5 years out from surgery. Now, by year 25, that number is still between 50 and 60%, so this is an extremely durable procedure as well. In fact, because it's been around for so long, it's really become the gold standard by which we measure success for all other bariatric procedures. Both the procedures that we're currently doing and new variations or experimental surgeries that we're in the process of trying to develop. So if these other surgeries don't have the safety profile and the efficacy of a gastric bypass, a lot of times they won't go any further. Now, Ruiny is performed when we go and we divide the stomach, making a small 2 to 4 ounce pouch. Then we pull part of the jejunum, the small intestine, up and connect it to that pouch. Where we took the intestine from down below, then we reconnect, and it makes a Y shape, hence the name Ruiny. But the point is that food then travels down, and in this image you can see that there's a red arrow. Food travels down along that track with the red arrow, and only once it meets the connecting portion of intestine, signified by the green arrow, where those arrows join, we call the portion of the intestine beyond that the common channel, and that's where the majority of food breakdown, digestion, and absorption occurs. Once upon a time, we thought that there was a significant amount of malabsorption related to a gastric bypass, but we find that with ongoing studies, that's really not the case. And in fact, the main benefit of a gastric bypass is its change on metabolism. And that's important to describe. So the duodenum, that C-shaped segment of intestine just beyond the stomach, is the hormone center for your entire digestive and metabolic process. And it responds, meaning that the signals to release certain hormones is actually food passing through the lumen, touching the inside surface of it. So when we divert food past the duodenum, it really blunts a lot of those metabolic responses and therefore changes the way we metabolize food in a really favorable fashion. It decreases our cravings, decreases our hunger. It does not allow our body to slow down our burn rate, so our metabolic rate, as we lose weight, which is where we see the long-term benefit of the gastric bypass on weight loss. So another potential downside or side effect of the Ruiny gastric bypass is what we call dumping syndrome. Now, because our gastric pouch is quite small and there's no valve between that gastric pouch and our small intestine, food is able to pass into our intestine sometimes very quickly. When people, after they've had a gastric bypass, eat things that are high in carbohydrate or sometimes just very rich foods in general, it can cause this syndrome where people for maybe half an hour, sometimes up to an hour, will feel not right. It's not often a painful experience, although they feel some kind of low-level nausea, a lot of abdominal discomfort, sometimes some diaphoresis or sweaty sensations, and oftentimes it ends with a diarrhea bowel movement. And so that can be really unpleasant for a lot of people, and it's definitely not something that we intend to have happen. Now, a lot of people come back to us and say that there's a silver lining. The fact that this usually occurs if people eat foods that they shouldn't be eating, it actually keeps them honest and helps them to avoid those things long term, and therefore may be something that contributes to their success in some way. But again, not something that we intend to have happen, and something that everyone needs to be aware of before they choose to undergo this type of procedure. Beyond that, should some other problem arise in the future, whether any number of things such as cancer or problems in the intestine related or not related to gastric bypass, and we had to go back and undo the surgery, it is possible, but it is quite difficult, and it takes a significant surgery to go and reverse this surgery. You know, after people have a gastric bypass, generally speaking, we keep them in the hospital overnight. And I would say 80 to 85% of people are able to go home the next day. There are a few people that for whatever reason we end up keeping in the hospital one more day, but the majority go home the very next. There are some surgical complications or post-operative complications that we do see and people need to be aware of. One of them is the possibility of an anastomotic leak. Now, an anastomosis is simply anywhere we connect intestine. So in the gastric bypass, we've got a connection between the stomach pouch and the small intestine, and we have a second connection where we connect the small intestine back to itself down lower. An anastomotic leak can occur if where we've connected the intestine, the tissue just doesn't heal quite right. If we find a leak early in that manner, most of the time it just means 1, maybe 2 extra days in the hospital. However, people are right back on track. If leaks are discovered several days to a week after surgery, sometimes it does involve a potentially longer hospitalization and more involved treatment such as drains, etc. Another potential complication is a stricture. So where we connect the intestine, the body deposits scar tissue. Now, scar tissue over time tends to contract. That's what brings the edges of a wound together after we've been cut, for example. Unfortunately, if we have a tubular structure and that scar tissue contracts over time, it can sometimes narrow that opening. Fortunately, that only happens between 3 and 5% of the time. And if it does, people can sometimes notice that, man, when they swallow, food just tends to stick. It doesn't pass through as easily. And in severe cases, it doesn't pass through at all, and people have to bring it back up. So we advise all of our patients that if they start experiencing symptoms like that, to come back to us. One of the other potential complications is what we call a bowel obstruction. And you can kind of think of this as a kink or a twist in your intestine that just doesn't let food pass through. That can occur anywhere between 1 to 2% of the time within the first year to 2 years. And it usually is a result of scar tissue at the time of surgery. So again, sometimes scar tissue on the inside of the abdomen can have untoward effects that are completely unforeseeable, and this is one of those. Other times these obstructions occur because of what we call an internal hernia. Again, something that we do our best to minimize the risk of, but can still sometimes occur in that 1 to 2% range. Whenever you talk about a surgery, it's important to comment on the potential risk of mortality. Every surgery in the United States that's done regularly has a mortality rate. And for a gastric bypass, that's about 0.2% nationwide. Usually when that happens, it's as a result of other complications such as a blood clot that forms and goes to your lungs, or a significant infection that could develop after surgery, and really not directly related to the surgery itself. But again, one of the reasons that we just insist that people follow up with us closely is to find any sign or symptom that may indicate something's wrong, so that we can intervene long before we get to the point that it's life-threatening.
but the most powerful operation is the duodenal switch. That what we do is we start by amputating the greater curvature of the stomach, turning the stomach into a tube. That's that vertical gastrectomy that's also called a vertical sleeve gastrectomy. And that has several different effects. First of all, we realize that in it alone has metabolic effect. Not only does it reduce your stomach so you eat less, but more importantly, it alters metabolism. The stomach is more complicated. There's different types of cells in the upper part, the fundus, and in the body of the stomach, or in the antrum, which is the distal part. And when those cells either come in contact with food or don't come in contact with food, it affects metabolism. And so when you take them out of the circulation, then we go down below the stomach onto the duodenum about an inch. The duodenum is the first portion of the small intestine, and we divide that. And then we go down to the colon and measure the bowel, develop what we call a Ruiny limb, which brings a part of the bowel up to, that we can bring up to the stomach to sew. And we measure that from the colon backwards. So that the food comes down from one side, the digestive enzymes come down from another. And again, they mix where you've sewn the bowel back together, and then the digestion, most of it absorption occurs in that common channel, which is the most distal portion. In the duodenal switch, that common channel is short. It's only about 3 feet long. Now, for 35 years, we thought about this operation in terms of behavior and said it works because the stomach is made small. But that doesn't really work because everybody can eat more with time, and that doesn't correlate with weight gain. So we've said, well, we're bypassing 90% of the intestinal tract, so therefore there's substantial malabsorption. You're not absorbing as many nutrients. In theory, you're only absorbing 10% of your nutrients, right? Well, the answer is wrong. The bowel has tremendous absorptive capacity. It also has tremendous adaptive capacity. With time, the bowel adapts, so it becomes more absorptive. And so what we find is that you absorb carbohydrates fairly normally. Protein absorption is decreased maybe 10%, but in some patients probably not at all. Fat absorption is decreased, anywhere between 30 to 80%. And again, we said, well, that works because, again, not absorbing fat will give you less calories. Fat's not really a big problem when it comes to obesity. When you look at the metabolism of fat deposition and obesity, it's really related to carbohydrates, not fats. But what it does do is if you have undigested fat that gets into the large intestine, that can cause gas and diarrhea. So for those patients that have DS, that's a good incentive for them to avoid high-fat foods. So again, it's very, very powerful. We see that patients, on average, lose greater than 80% of their excess body weight. On average, less than 10% are regaining their weight at 10 years. So very powerful weight loss, very durable operation. And again, to demonstrate its metabolic effect, we see that over 95%, anywhere from 95, in our experience, 98% of our type 2 diabetics go into remission, meaning that the disease goes away. That's compared to a gastric bypass, which is about 80 to 85%, which is excellent, versus a sleeve, which is about 70%. Most of them go into remission within the first 2 or 3 days after surgery, definitely within the first 2 weeks. So very, very powerful metabolic operation. Downside, increased complications, okay? It is more complex, and therefore there are more risks, such as leaks, to occur. Nutritionally, you have to pay attention a little bit more. Not a lot, but a little bit more, because you can get into some nutritional problems.
Whenever we undertake a surgery, there are inherent risks. So with any major abdominal surgery, this could include having your gallbladder taken out, getting your appendix removed, really any surgery where we're going into your abdominal cavity, there is a risk of developing what we call a pulmonary embolus. Now what that is it's a blood clot that usually forms in your legs and can break free and go to your lungs. That happens anywhere between 0 and 3% of major abdominal procedures done in the United States. Fortunately, only a very small number of those are fatal, and that's unfortunately about 0.5%. So, 1 in 500 of people that get pulmonary emboli, it can be fatal. Usually what we see, though, is if we notice before it has broken free and go to the lungs, people can develop a swelling in one leg or pain in their calf, and that alerts us that there may be a blood clot, which if we identify, we can treat before it ever causes problems with the lung. Unfortunately, sometimes we don't know about the blood clot until it has broken free and traveled to the lungs. And what that does is it blocks blood flow to a portion of the lungs. So even though you're breathing oxygen just fine, the oxygen can't get into your bloodstream. And what we find is people start to breathe rapidly, their heart rate goes up a little bit, and again, that can alert us that something's not right, and we can look for, do some tests to identify a pulmonary embolism. If we do identify either a blood clot in the legs or a blood clot that's gone to someone's lung, we treat that with anticoagulant medications that people need to take for several months, and generally at that point they can stop taking them and go back to normal. But it is something that we watch very carefully for. Again, for comparison, we see the same rate of pulmonary embolism and blood clot in gallbladder surgery or any other abdominal surgery. Interestingly, the rates of blood clots and pulmonary embolism are significantly lower in this type of surgery than they are for orthopedic procedures. Another thing that, again, is a risk factor in general for surgery is the risk of bleeding. At the time of surgery, we assure that there's no bleeding prior to finishing the procedure, but in some cases, after surgery, if people's blood pressure gets high, or in some cases we never identify really a reason why, people can have bleeding. Sometimes that requires us to go back to the operating room and kind of wash things out and find that bleeding vessel and seal it. Other times it could simply require a blood transfusion, and that's all. But it is something that we watch for very carefully, and it does happen from time to time. Furthermore, as we've spoken of earlier, leaks where we make connections of the intestine can occur. Fortunately, it's very low likelihood. Bowel obstructions and internal hernias can occur between 1% and 3% of the time. After we've modified the way our body ingests food and processes it, we also see some changes in the way our body absorbs vitamins. And in cases like dealing with iron, B12, and calcium, we notice that there's a decreased ability to absorb those things. And that's, again, the reason that we administer multivitamins daily. The surgeries that we perform currently all have some significant change in metabolism, some metabolic effect. And surgeries that have the greatest metabolic effect tend to be the most effective at helping people lose weight, keep it off, and also resolve some of the comorbidities they may experience. Whereas the procedures with the least metabolic activity still do all of those things, but maybe not quite as effectively. And I like to put these surgeries on a spectrum. On one end is the duodenal switch, which is the most powerful metabolic procedure that we have. We're seeing people losing between 70 and 90% of their excess body weight and keeping it off for 5 years. We're seeing 90 to 95% resolution of diabetes. In the middle of the spectrum is the gastric bypass. And again, patients can generally expect to lose between 60 and 80% of their excess body weight and keep it off for 5 years. We're seeing between 75 to 85% of patients with diabetes having complete resolution within several weeks of surgery. And on the low end is the gastric sleeve. And people are seeing between 50 and 60% excess body weight loss at 5 years, and between 70 and 80% resolution of diabetes.
So when we think about these surgeries as a tool, like anything else, there's two parts to it. One is actually having the surgery and making sure it's done well, effectively, and safely, and that's where we obviously are here to help with that. The second part is the partnership of you making the right decisions, deciding to eat the right kinds of foods, the ones that are rich in nutrition, high in protein. Obviously, we're going to want to avoid foods that are high in carbohydrates, sugars, and fats, and keeping that portion size down, drinking lots of water, not liquid calories. So there's a real partnership that goes there, having a well-done surgery along with good compliance afterwards. And when we see those two things going together, really amazing results can happen.
We're here to give you information that you can use to make an informed decision about what's best for you. We're not here to talk anybody into anything. We want you to continue to do your homework. Talk to people who've had these surgeries. Talk to people who've done well. Talk to people who've had problems. But I counsel you to talk to the individual. The choice is yours whether weight loss surgery is for you or not. If you tell me that it's not, that's fine. If surgery is for you, it's up to you to determine which procedure that you want. We're not going to tell you. We're going to help you make that decision by answering your questions. Now, there are a number of obstacles to surgery. So many times I hear from patients, well, you know, everybody tells me this is the easy way out. This is not the easy way out. Unfortunately, that's the only way out, and for many of our patients. So we want you to really talk to your family, talk to people and understand, help them understand. Insurance can be an issue, we understand that, but bariatric surgery is a very unique area in medicine. It is one of the only areas of medicine that is actually cost effective. We actually save the healthcare system money. Other obstacles is just the fear of surgery, and as I've said in other portions of this, the risk is there, but the risk compared to other operations is not as high. We've tended to inflate the risk and the fear that goes along with it. On the other side, we tend to diminish or tend to underestimate what the damage of obesity has done. Obesity is now one of the world's largest problems, and yet we tend to treat it as nothing more than a personal body image issue rather than a real health issue, when it is really a major health issue. So you need to look at yourself and what problems you really have and what you're really trying to accomplish and what risks you're really willing to take in order to get this done. And then take a consideration of which operation is best for you.
You may be thinking, what do I do next after viewing this online seminar? In this case, you're going to want to take the online post-test to make sure that you've captured the information that we've talked about here. And then you'll proceed to submit your application so that you can come in for a consultation so that we can talk more in detail with you about your health, your medical conditions, which surgery is right for you, and to make sure that you're a good candidate for weight loss surgery.